we are going to talk about colorectal tumors. Before I go into the depths of the colorectal tumor, this is a general outline which you can use for any tumor. So when you have taken a focus history, when you have done a focused examination, you will come up with certain diagnosis. So for tumor, you need to confirm your diagnosis. And you have different modalities. You can use imaging, you can use some endoscopic examination or certain other specific investigations which may be different for different tumors. So imaging, commonest imaging is ultrasound, CT scan, MR. So this can help you confirm your diagnosis besides giving other information also. Gastroscopes, colonoscopes, endoscopic pancreatography, ERCP. So there are a lot of endoscopic examination which we can do to confirm our diagnosis. So when we have confirmed our diagnosis, we need to take a biopsy. You need to take a tissue diagnosis of that tumor. So you can take a biopsy by different route. It can be a fine needle aspiration cytology, it can be a true cut, it can be incisional biopsy, it can be excisional biopsy. True cut is a special needle which take a piece of this tissue itself. FNSE is slightly different because we just put a small needle and just take few cells. So this is a cytology. The rest of the biopsies are for tissue diagnosis. When you have confirmed your diagnosis and you have a confirmation of the tissue diagnosis also, okay, this is a tumor, you need to stage the disease, how far it has already spread. And for that, you will again, first of all, need some imaging, which may be in the form of CT scan, MRI, sometimes PET scan, and sometimes certain different tumors can help. The radionuclide scan can help you. When you have a diagnosis based on your clinical data, that is history, examination, you will stage the disease according to the clinical data. When you have a tissue diagnosis, a histopathological diagnosis, you will stage the disease according to pathological data. So the staging can be with the help of grade, the TNM, the most common widely accepted TNM classification, and it is written C and P. This is clinical TNM and this is pathological TNM, and the staging of the disease, which incorporates the TNM and defined in a much simplified form. And for certain tumors, some specific staging we will see in colorectal also. Okay, there are some specific staging for the colorectal also, specific names. So grading is a pathological grading. The tumor can be well differentiated, poorly differentiated, we will see that. So once you have staged the disease, you have confirmed your diagnosis, then you have to manage the patient. You have to give a treatment plan. For first of all, you need to talk to the patient and relatives what is going wrong with the patient, because it's a serious problem. So you need a proper counseling, a proper informed consent from the patient and from their relatives. Very important. Then you advise a treatment plan. Generally, tumors are for surgeons. Not all, but generally, depending upon the stage of the tumor are for surgeons. So surgical treatment is the top choice for any tumor. You have to remove the tumor. You have to get rid of that tumor burden in the body. Then is the radiotherapy, chemotherapy, and sometimes hormonal therapy for different set of tumors. Which one is the first you want to give? That can also vary in different tumors and according to the different stage of the tumor. So that is why I told you that relevant treatment plan is very, very important. Sometimes we'll be doing surgery first, sometimes we'll be giving chemotherapy first or radiotherapy first, and sometimes start with the hormonal and continue with the hormonal. So these things will vary. Once you have done your treatment, then comes the follow-up. Follow-up for two reasons: to see any complications what the treatment you have given, and also any recurrences of the tumor which can happen, any spread of the tumor which can happen later on. And if you have done some major resections or some major part of the body has been removed, or patient has some psychological disturbances after this problem or chemotherapy issues, so patient will need some rehabilitation. So these are the commonest tumors which we can see in colonic area and the rectal area, and the most of the bulk is taken by the adenocarcinomas. About 90% plus of colorectal tumors are adenocarcinomas, which can be mucinous and signet cell rings. And there are other varieties, but these are the most common varieties. In addition, we can see some carcinoid tumors, which you must have heard related to the appendix, but it can happen anywhere in the colorectal areas. Lymphomas can happen everywhere in GIT as well as in the colorectal area. Gastrointestinal stromal tumors, GIST. This is also a common tumor which you can see anywhere. Then comes the leiomyosarcomas and sometimes melanomas, not very common, but the patient can come. Usually it happens in the cutaneous areas, the tumors of the anal canal, and sometime in the lower rectum also. Colorectal tumors incidence is rising, and majority of the tumors happen in the colonic areas, and 1/3 of the tumors happen in the rectal area. Now this term adenoma carcinoma path, colorectal tumor always start from a benign pathology, which is adenoma, and then later on is and convert into the carcinoma. Colorectal carcinomas are notorious with this APC gene. So this is the precursor of the colorectal cancer, and those adenomas, those patients who has these adenomas and they come up with this identified APC, they will have the carcinoma later on. And this is the initiating gene which start the process of this cascade of the events which convert into a simple benign pathology to a malignant. Then comes the KRAS. It stands for Custine Rat Sarcoma. So this is also initiating factor. Another gene mutation when happens, which is another initiating factor for this cascade. And then P53 proteins, if they are present, this shows the signs of aggressiveness of the tumor. The tumor is invasive. It always starts from small polyps, and these polyps can vary in different histological pattern, and the most notorious polyps are the villous adenomatous polyps. So this is the adenoma carcinoma pathway. It starts from the normal colon up to the carcinoma with invasiveness cause of P53 mutation, and this is the APC proteins which are present, which is later on followed by KRAS, which actually KRAS acts as a signal for these oncomutations, and then later on invasiveness starts, and this is the cascade. This is another diagram showing a normal colon endoscopic view, and later on converting into a small polyp which is pedunculated. This is a pre-cancer, and then later on the polyp has changed its shapes and formed a cancer. And this cascade usually takes about a decade, 10 to 15 years. So these polyps start in early teens, and the patient will have, if they start in early teens, the patient will have the cancer in 25 years plus age. So what are polyps? Polyps are small pedunculated protrusions of the mucosa, and there are basically 4 types of polyps: inflammatory, metaplastic, neoplastic, and hematomatous. They can happen as a single polyp anywhere, and they can happen as a multiple that can have hundred of polyps. These 3 conditions, adenomatous polyps, FAP, familial adenomatous polyps, and hereditary non-polyposis colorectal cancer, which is also called as Lynch syndrome. Try to remember these terms because these are important for examination point of view. The other term you should be knowing is Peutz-Jeghers polyps. So this is a polyp, a simple benign polyp. There are 2 types of polyps: a tubular polyp, which is sort of a long stalk like a berry on a stalk, and a villous adenoma, which are these flat lesions. So villous adenomas have more malignant potential. Patient will come with simple rectal bleed at an early age. Sometimes the rectal tumors, which the polyps can have some mucus discharge. So the simplest examination is to do a DRE, digital rectal examination. If you can feel the polyp, all the polyps has to be removed. You can use a colonoscope. If the polyps are very small, you can use a snare. Flattened, broadened lesion, you can use some this endoscopic mucosal resection. This can be done by colonoscopy. And if there are very large lesions, then you have to do a surgery from anal canal, which is called transanal endoscopic microsurgery. The other name is TEMS. So you can use this, and you have to take a biopsy. Any polyp more than 0.5 centimeters, some books say it's 1 centimeter, they have to be removed, because if the polyp is about 1 centimeter size, the incidence of malignancy is 10%, and if the polyp becomes 3 centimeter, the malignancy incidence becomes 30%. So all the polyps greater than 0.5 centimeter has to be removed and tissue diagnosed. So familial adenomatous polyposis, this is a syndrome. It is autosomal dominant, runs in families, and this characterized by presence of hundreds of adenomas, and sometime in duodenum also, and sometime some extra colonic or extra-intestinal manifestations like epidermoid cysts, like brain tumors, desmoid tumors. So this can happen anywhere, in gastric glands, in stomach also. So patient will have positive family history, and in this case 20% will have some mutation in the APC gene. And if you diagnose FAP in a person, he has a risk of colorectal cancer 100%. And because it has a very strong family history, all the siblings, all the brothers, all the sisters, even if they do not have any symptomology, they need to be screened. And if everyone is confirmed with the diagnosis of FAP, some sort of prophylactic surgery is indicated. If you find a child who's 10 years or 12 years, you wait up to 15 years to see how it behaves, but not more than 15 years. All the FAPs are usually diagnosed before the age of 30 years. And if there are no adenomas by the age of 20 years, then FAP is very unlikely. So what you will do in a patient who has FAP, you will think that he is going to get cancer at the age of 20 plus or 25 plus. So he would need some prophylactic surgery. His brothers, his sisters, his family members, if they remain undiagnosed somehow, they will need some surgical options. We have seen patients, the mother has brought the child diagnosed as FAP. When we surveyed, screened the father or the mother, they had positive colorectal cancer. So the answer of treatment for FAP is colectomy. Just remove whole of the colon. And if you remove the rectum also, this is called proctocolectomy. Obviously, when you remove the colon, you have to anastomose the ileum with the rectum. And if you have removed the rectum also, you have to anastomose the ileum with the anus. And sometimes it is not feasible to anastomose, so patient will end up in endoleostomy, which can be later on reconstructed. So what is the treatment option for diagnosed case of FAP? The answer is, without cancer, the answer is total colectomy. And if a patient who has diagnosed case of FAP and now has come with a colorectal cancer of sigmoid colon, let us assume, the answer would again be total colectomy. And any portion of the intestine you have left, if you have left the rectum, you have to yearly biopsy the rectum for cancer screening. And if later on you find this rectum is changing, this has to be removed. The other important syndrome is the HNPCC, another autosomal dominant condition, and this has 80% chances of colorectal cancer. The other characteristic of this is associated with the cancer of endometrium and cancer of the ovary and stomach and small intestine. So there are two criteria for diagnosing this hereditary non-polyposis colorectal cancer. Ideal investigation would be genetic testing. All the patients who you are suspecting should have genetic testing. But sometimes genetic testing is not possible. So we use this Amsterdam type 2 criteria. So first of all, you need to have some histopathological examination. Then FAP has to be ruled out. And at least one tumor should have been diagnosed before age of 50 years. And one relative should be first degree. So these are the few criteria. If the person fulfill these criteria, we'll label it as HNPCC. So what causes these colorectal cancers? Genetic, I have already told you. So there are certain hereditary factors. You can't change it. If you have it, you will develop the cancer. Then there are certain risk factors which are modifiable, which are under your control. If you take care, you will not develop the cancer. Smoking, meat, processed meats. We can include fast food in this. Alcohol intake, red meat, low fibers, low fruits, low intake of vegetables. If person is obese, high BMI, so these are the factors which increases the risk, and all of them you can modify, you can change. This is under your control. And these factors, if you do it, they will decrease the risk. Your activities, high fiber diet, dairy products, fish intakes, nuts, plenty of vitamins, calcium supplements. So these modifiable, these are also under your control, and they will decrease the risk. Some other factors related to drug-induced, statin-induced, HRTs. Male are more prone to develop colorectal. Type 2 diabetes are more prone to colorectal. Same is with the inflammatory bowel disease. They are more prone to colorectal. So how does a patient of colorectal tumor present? They can present to us in emergency or they can present as an elective case. When they come in an elective case, they come with abdominal mass, with the bleeding per rectum, weight loss, altered bowel habits, constipation, diarrhea, tenesmus, anemia, and when they come as an emergency, they can come as obstructive lesion causing large gut obstruction. The tumor can perforate. The tumor itself can perforate, or tumor can cause obstruction, and that obstructed gut can also perforate. And all these perforated tumors present as peritonitis. And we say when the tumor is perforated, whatever the TNM classification or staging was before, now it will change and it will convert into stage 4. The tumors can bleed, and they can bleed massively. And patient can present with metastatic disease to the liver, to the lungs, with their associated issues. So how would you manage the elective cases will be different, and how would you manage the emergency cases will be different. In emergency cases, the main aim would be to save the life first of the patient. And when the patient is optimized, resuscitated, then you have to deal with the tumor. So again, another slide showing different symptomology of the colorectal tumors, the bowel habits, bleeding, abdominal pain, lethargy, jaundice, unexplained weight loss, emergency presentations, distension, peritonitis, perforations, rectal bleed. Very interestingly, the right-sided colonic tumors and the left-sided colonic tumors, they behave different as regards the symptoms are concerned. Why is that? Because cecum, ascending colon, and part of the transverse colon, the lumen is larger as compared to the descending colon and the sigmoid colon. The contents are more semi-solid on the right side. When they go to the left side of the colon, they become more solid. So that is why on the right-sided tumors, when they come to you, they don't come very early. They come late. The tumor start bleeding. The patient will have anemia. The tumor will become big in size. The patient will have some mass in the right iliac fossa, in the right hypochondrium, in the right paracolic gutter, and certain other non-specific symptoms. But on the left side, they present early because they obstruct early. They alter the bowel habits very early because the contents are different. The lumen is narrow. So left-sided tumors present early and the right-sided tumor present late. So right-sided tumors in the cecum, ascending colon, you can see they could come as 70% of these patients will come as abdominal mass. Other symptoms will be there, but mostly mass, anemia, weight loss, painful areas, because these tumors get time to get bigger, get time to spread. The left-sided tumors, less chance of mass, bleeding will be more, change in the bowel habits will be more, 60%. Patient will have obstructive symptoms, 20%. On the right side, it is 5%. And the rectal tumors, because they are very close to the anal canal, what will be the major symptom? Bleeding and the change in the bowel habits, which will be immediately reflected. 80% change in the bowel habits signifies that something is going on in the rectal area. Now, how the tumors are distributed? The most common site of the tumor are the rectums, 38%, followed by the sigmoid colon and cecum. The rest you can see very well. So the most common tumors what we see in our clinical practice are the rectosigmoid area, which are the most commonly affected tumors. So how you are going to investigate? General investigation and specific investigations. General investigation, the main purpose would be you as a surgeon, you will be planning for some sort of surgery. So you need to have some investigation for the patient fitness for surgery, fitness to get general anesthesia. So you will have some blood counts, renal function, liver functions, coagulation profile, chest x-ray, ultrasound abdomen as a part of general investigation to see any involvement of the liver mets. Chest x-ray, which can show you the chest x-ray, as such lungs also if there are any mets there. The specific investigation, fecal occult blood is not evident to the patient and it is hidden. So this test is not used for diagnosed or confirmed cases of carcinomas, but it is basically used for screening purposes. In those areas in those families which are high risk groups. So we use it as a screening. CEA level tumor marker, carcinoembryonic antigen levels are not used to confirm the diagnosis. They are basically have prognostic value. It means a patient who has diagnosed case of colorectal cancer may have high level of CEA, but you will not diagnose it with the help of CEA. But after surgery, and follow the patient with CEA level, because if the CEA level after the treatment start rising, it means the tumor is recurring. So it has a good prognostic value. Then proctosigmoidoscopy and colonoscopy, you need to see the tumor, you need to take a biopsy of the tumor, ultrasound abdomen, as well as the endoanal or endorectal ultrasound. The other name is transrectal ultrasound, TRUS, for lower rectal and anal canal tumor. This is a very good investigation, very easily tell you the presence of the tumor and also the local and the regional spread of the tumor. CT abdomen and pelvis, this is also very good with double contrast. MRI. For colonic tumors, the CT abdomen pelvis is preferred. For rectal tumors, MRI is preferred because the part of the rectum, most 2/3 of the rectum is extraperitoneal, and the lymphatic spread of the rectum is behind the rectum in front of the sacrum. To see that portion, MRI pelvis for rectal tumor is much preferred. The CT will not give that much. It can give certain clues, but it will not give that much information. Generally, what we do is when a patient comes with a chronic tumor, we get a CT chest, abdomen and pelvis as a part of initial survey, because chest mets can also be seen by CT scan. But chest X-ray is also not bad. It's very quick, and if you find chest X-ray mets in the chest X-ray, that is more than enough. Contrast studies, simple contrast studies you can do, but if you have a CT abdomen with contrast, that would be a better. Simple contrast study means you ask the patient to drink barium or you give a barium enema and take an X-ray. But CT abdomen pelvis is much more specific. PET scan, positive emission tomography scan, is not usually used as an initial part of investigation, but it is usually used later on for recurrences, or if the CT or MRI is doubtful, it doesn't pick the tumor, and your history and examination tells you there has to be a tumor, and the CT and MRI is not picking the tumor. So at that confusing point, you can use PET scan initially, but usually PET scan is reserved for later cases. So this is a proctoscope with the obturator. Proctoscope varies in different sizes. This is a sigmoidoscope. It has a light source. It has this tube with a bellow at the end to inflate air, and this light source which illuminate. And this is a full-length colonoscope. Imaging, double contrast barium enema, you can see apple core deformity, another deformity. CT scan, you can use CT virtual colonoscopy, and as I already mentioned, rectal cancer requires MRI. So these are a few pictures. This is a CT scan showing liver. This is a big liver. This is a vertebra. This is the spleen. This is a huge liver which is enlarged and shows many small dark areas. These are the liver mets. This is the aorta. This is another CT scan, vertebra, aorta. This is the right side, left side. This white area is a contrast in the small gut. And this large mass present in the right side of the abdomen is the cecal tumor, carcinoma of the cecum. This is another diagram showing another mass, probably in the hepatic flexure, because this is the cecum now. So this is slightly distal in the cecum, and this in the hepatic flexure or in the transverse column. This is TRUS, transrectal ultrasound. This is the probe, and this is the anal canal. These whitish structures, if you can appreciate, these are the sphincters of the anal canal. These white lines, white circular lines, and in this area you can see there is sort of a gap or sort of filling defect, and all the sphincters are gone. So this is a locally advanced anal tumor. So you can well appreciate how these tumors can spread, and this investigation can be very important. So basically, when you see the tumor with the colonoscope, these 4 types you need to remember. It can be an annular variety, it can be a tubular variety, it can be a sort of a polypoidal or a cauliflower growth-like variety, and it can be ulcerative variety. So these annular, tubular, cauliflower, ulcerative, 4 types you need to remember. Ulcers and cauliflower growth can bleed. Annular and tubular can obstruct. And when you see under the microscope, you will get well differentiated, moderately differentiated, poorly differentiated. Obviously, poorly differentiated will have worse prognosis. Well differentiated will have good prognosis. How the tumor spread? The colorectal tumor spread by locally in a longitudinal direction of the colon, circumferentially around the structures around the colon, the rectum. They can all get involved if it spread locally. So that is why CT and MR can tell you what is the loco-regional extent of the tumor. It can involve the ureter behind the colon, it can involve the duodenum on the right side, it can involve the pancreas on the left side, in the rectum can involve the prostate, the seminal vesicle, the vagina, the uterus, and lymphatic spread, the most common spread of the colonic tumors, via blood to the liver, chest, adrenals, brain. And sometimes the local shedding of the tumor from the serosa can cause it as a peritoneal mets. So this is the lymphatic slide. 3 stations, red, blue and yellow. So red stations are the pericolic stations, pericolic or epicolic. You can see they are present on the marginal artery of Drummond. Then come the main vessels, the ileocolic branch of spira mesenteric, the right colic, the middle colic, the left colic branch of inferior mesenteric. These blue, they are called as the principal lymph nodes. Principal lymph nodes. Then come the yellow. They are the central group of lymph nodes. They are present on the main vessels, the superior mesenteric artery and the inferior mesenteric artery. And the white node are paracentral. They are actually present on the aortite side. Tumor is present in the cecum. The more lymphatic clearance you can do up to at least up the central lymph nodes is a must. The better the tumor surgery would be. Because if you just remove the cecum, you leave all the lymph nodes, it is incomplete, inadequate surgery. So you have to make a V from cecum. You make a V like this. So tip of the V would be the main vessel, the yellow part. So once you have a clinical diagnosis and once you have sort of a radiological or imaging diagnosis, you have to stage the disease. There are various types of the staging which are available. And why we need to stage the disease? Because we need a good staging system, because we have to develop an adequate treatment plan. And how we develop the treatment plan, we want to see by imaging, by clinical examination, by imaging whether the tumor is resectable, whether there is already metastatic disease. And for that, CT chest, abdomen and pelvis is the ideal investigation as a staging scan to tell us about the resectability and the local spread and the metastatic disease. And these clinical staging are based on the preoperative imaging. Then we do the surgery and send the specimen to the pathologist, and they will do their staging, pathological stage. So then we join these together and we'll come up with clinico-pathological stage. The TNM classification is the international recognized classification. T stands for tumor, nodes and metastasis. This TNM classification is almost same for the rectal tumors as well as the colonic tumors. T we divide into 4 stages. T1 is the early cancer which just have invaded the submucosa, and the T2 reached the muscular propria of the bowel wall, and T3 is the tumor which has spread beyond the muscularis propria and is entering the serosa, is just touching the serosa, but it is still contained in the bowel wall. It has not gone out of the bowel wall. And T4 is advanced cancer, which actually comes out of the bowel wall. You can see on the intestine the tumor is coming out. It breaches the serosa of the bowel wall. Then the nodes, the lymph node status, and there are no lymph nodes on the wall. Patient will have a good prognosis. And if there are up to 3 lymph nodes, somewhere it is written up to 4 nodes, it is called as N1. And if 4 or more lymph nodes are present, they are called as N2. And then obviously metastasis is present or not. Metastasis means beyond the bowel wall into the adjacent structures or into the systemic mets, into the liver or in the chest. This is a sort of a clinico-pathological classification. If you can see on the corner, this is stage 0, and stage 0 is just starting off the tumor in the mucosa. And stage 1 actually includes, it's a superficially invasive cancer. You can say it is T1 and T2 combined together is stage 1. And these white structures outside the bowel wall, outlined by the green, are the lymph nodes. And stage 1, stage 0 and stage 2, you can see there are no lymph nodes involvement. And stage 2 is basically more deeper involvement of the bowel wall without lymph nodes. So these 2 stages, including stage 0, are basically called the early bowel cancers, or anywhere other tumors, they are all called early cancers. When we come to stage 3, whatever the size of the tumor, T1, T2, T3 or T4, the important point is the involvement of the lymph nodes. So when the lymph nodes get involved, the stage is advanced. And you can see the tumor is coming out of the serosa also. The T doesn't matter in stage 3. The main problem is with the lymph nodes. And when we come to the stage 4, the T and doesn't matter. Whatever T, whatever N, the main problem is localized or distant metastasis spread to the other organ, and this will determine the prognosis of the disease as well. There is another staging system which is called the Duke staging system. Initially it was designed for rectal tumors, but nowadays they keep it for all the colorectal tumors. There are 3 Dukes: Dukes A, Dukes B and Dukes C. So Dukes A is the invasion of the bowel wall, and B is the against the it has gone beyond the muscularis propria but has not involved the lymph nodes, and the C is which is actually stage 3 in which the lymph nodes are involved. And after Dukes there was another person with the name of Collins who added another stage which is called as a D stage. In that scenario it is called as Dukes-Collins stage, and that points towards the metastatic disease. So what are the treatment options for the colorectal tumor? Colorectal tumor generally are for surgeons, and the best treatment options would be surgical. Then come the systemic chemotherapy, which can be given preoperatively as a neoadjuvant or as a postoperative. Same is radiotherapy, neoadjuvant or adjuvant. Then there come certain palliative methods in case of advanced tumors. Either you can give only chemotherapy or chemoradiotherapy. You can just treat the patient symptomatically. You can't do anything. The tumor is so much advanced. Or if the patient has come with sort of obstruction due to this tumor, you can defunction in colostomy or ileostomy so that he is able to move his bowels. For the tumor, we can't do much. So these are the treatment options. We will see one by one. And which treatment option you want to give first will depend upon the stage of the tumor. Generally for colonic tumors, surgery is the treatment of choice. And generally for the rectal tumor, the first treatment choice is chemoradiotherapy, depending upon the stage of the tumor. So we'll start with the surgical options first. When you are planning for surgery, you need to prepare the patient. And in preparation of a cancer patient, you need to take an informed consent, and you need to tell the patient that there is a possibility that you may end up with a colostomy or a ileostomy, which may be temporary or which may be permanent. You need to arrange some blood. Bowel preparation. Obviously, you have to prepare the colon. You have to get rid of all the fecal matter in the colon because you want to operate on the colon. This is called as a mechanical bowel preparation. I have put a query in front of bowel preparation because nowadays recent studies have shown that mechanical bowel preparation is not that helpful, and the results of surgery with or without bowel preparation in elective scenario is almost the same. But if you don't prepare the bowel adequately, there will be chance of wound infections. For lower rectal tumors, unprepared bowel have more problems. So in rectal tumors, bowel preparation is better than not preparing the bowel. Then come the thromboembolism prophylaxis. This is very important in all major surgeries, especially in the tumor surgeries. They have higher risk of thromboembolisms. So we have to give some prophylaxis. We usually give low molecular weight heparin preoperatively as a chemical method, and also we give some manual compressions, stockings or boots, which will continue preoperatively and continue through the operative period till post-operatively. And this prophylactic thromboembolism, low molecular heparin will continue as post-operative also for at least a month or so. Prophylactic antibodies are usually given routinely, and whether to give post-operatively depends upon the condition of the surgery, how well you have performed, how much the spillage was there, how much contamination was there, and what was the condition of the patient. Then comes the term the enhanced recovery program. So what is enhanced recovery program? They have seen in colorectal cancer that because of the magnitude of the surgery, patient takes lot of time to recover, and usually a week to 10 days was a norm before, because of the presence of nasogastric tube, because of the IV fluids, because of giving antibiotics. Enhanced recovery program start pre-operatively. There are the various steps of this enhanced recovery program. The basic objective is to get the patient out of bed and out of the hospital in the best possible condition. It always starts from the pre-admission counseling. You have to tell everything about the surgery. You have to counsel the patient thoroughly. Mechanical bowel patient, as the people say, they increase the mobility and increase the stay. So whenever there is possible to avoid the bowel operation, it is avoided. Patient should not be dehydrated pre-operatively. Nowadays, we don't put nasogastric tube routinely. Incisions are now converting from large, long incisions to short incisions, and now the laparoscopic surgeries have basically eliminated the need of long post-operative stays. Modification in anesthesia practice. Rather giving general anesthesia, these surgeries can be done in epidural anesthesias. We don't like to give opiates post-operatively. This can also help in recovery of the patients, and encouraging early mobilization and early removal of the drains. So all these steps can help in early recovery, and this has significantly reduced the mobility of the surgery itself also. So what are the treatment options, surgical treatment options of various tumors? The tumor can happen in the cecum, transverse colon, descending colon, sigmoid colon, and the rectum. When you remove the right colon, the treatment is called as right hemicolectomy. When we remove the left colon, it is called left hemicolectomy. When we remove the transverse colon, it is transverse colectomy. When we remove the sigmoid colon, it is called sigmoidectomy, or sometimes people refer it as high anterior resection. And when we remove the rectum, call it as low anterior resection. And if we have to remove the anus also, that is called as the abdominoperineal excision or resection. So this is a slide showing the right hemicolectomy marked in yellow. So if the tumor is in the cecum, ascending colon, and in the hepatic flexure, this right side of the colon has to be removed. You can see when you remove the right colon, the blood supply of the right colon has to be removed, including the lymph nodes and the mesentery of the right colon, which is called the mesocolon. And mesocolon contains all the lymph nodes, the pericolic lymph node, the central lymph nodes, and the apical lymph nodes. You know by your anatomy what structures lie behind the right colon. If you start from the upper side, behind the hepatic flexure, there will be part of the duodenum. And if you come down in the ascending colon, there will be part of the kidney, the ureter, the gonadal vessel. So whenever we are doing the right hemicolectomy, we should be aware of these structures which are behind. And in Duke C classification and in stage 3, we know that this is locally advanced tumor. So tumor have tendency to involve these neighboring structures. In the upper part, it can involve the duodenum. In the middle part, it can involve the kidney, the ureter. In the lower part, also it can involve the ureter. So we have to be very careful when we are ligating the vessels, and we have to be careful of the structures behind. And the vessels we ligate will be the ileocolic vessels, the right colic vessels, and the right branch of the middle colic branch. So these 3 vessels are ligated. This is the term which is called the extended right hemicolectomy. Suppose the tumor is on the right hepatic flexure. Obviously, we need a good clearance for the surgery, so that the recurrence chances are minimum. So we extend this surgery to the mid of the transverse colon. So now we have extended our right hemicolectomy involving to the mid of the transverse colon. And by doing so, we have actually, rather ligating the right branch of middle colic artery, we have ligated the middle colic artery itself. So this is called right extended hemicolectomy. And when we are extending the surgery to the transverse colon, we know that the pancreas will come in posteriorly to this transverse colon, and above the transverse colon will be the stomach. So these will be the more structures which we have to be careful. So hemicolectomies and right extended hemicolectomies are basically for tumors of the cecum, ascending colon, hepatic flexure, as well as the proximal transverse colon. When you have done the right hemicolectomy, you will be left with the transverse colon and the ileum. So naturally you have to unite ileum and the transverse. So right hemicolectomy, you remove the part of the colon and unite the remaining ileum with the transverse colon. So ileocolic anastomosis. Same is true with the right extended hemicolectomy. When you do the transverse colectomy of the tumors for the mid of the transverse colon, you have to ligate the middle colic artery and part of the branches of the left colic artery, and you have to unite both of the colon together. Now there is a debate about this transverse colectomy versus the extended right hemicolectomy. Some people say that instead of doing the transverse colectomy, you sort of do a more extended right hemicolectomy so that you can unite the ileum with the transverse colon, because doing the primary anastomose with the colon to colon, the anastomotic leakage is slightly higher as compared to uniting the ileum with the colon. So ileocolonic anastomose is more safer as compared to colocolic anastomosis. But this is a segmental resection which you can do if needed. Then comes the left hemicolectomy. When you have removed whole of the left colon, the splenic flexure, the distal transverse colon, the descending colon, and part of the sigmoid colon by tying the branches of the inferior mesenteric artery. This is the left hemicolectomy. Obviously, what will be the structures behind this side of intestines? In the upper part, there will be spleen. Then there will come the tail of the pancreas, then come the left kidney and the ureter. So these are the structure we should be aware about so that we may not injure this. And we will unite colon with the sigmoid colon. So colosigmoid anastomosis. When you remove the sigmoid colon, you ligate all the branches, sigmoid branches. This will be called sigmoid colectomy, obviously for the tumors of the sigmoid colon. When you go down in the rectum, this will be called as anterior resection. So when you remove the rectosigmoid junction and the rectum upper part and the middle part, leaving the lower part, this is called as anterior resection. And when you remove whole of the rectum, even the lower part for the tumors of the lower rectum, anal canal, then it would be called as abdominoperineal resection. Why? Because the surgeons will operate from anterior abdominal part and part of the surgery would be done from perineal area. So that is why it is called abdominoperineal dissection. And this graphic diagram showing the yellow line or orange line, this shows presence of the lymph nodes and removal of whole of the anal canal, the rectum and the sigmoid colon with the mesentery and the mesorectum. This is the abdominoperineal excision or resection for the lower and the middle rectum. Our objective is always to save the sphincters, because if you remove the sphincter of the anal canal, the patient will end up in a permanent colostomy. What about emergency surgeries? So far, I have talked about surgeries which are done in elective prepared patients. Emergency surgery, patient comes with obstruction or with the perforation, peritonitis. So in that case, patient may not be stable, patient may not be optimized. You may be able to resect the tumor, but it will be in unprepared gut, in unprepared patient, without CT scan, without any investigation. So in emergency surgery, we just try to relieve the obstruction by either diversion or just simple resection, and do not try to primary anastomosis. Hartmann procedure is usually reserved for rectal tumors or the sigmoid tumors and the lower rectal tumors. In this way, if the surgeon is able, patient usually present as an obstruction. And if the surgeon is able to resect the tumor, that will be the ideal situation. But he will not primarily unite the two ends together. He will bring out the proximal colon as a colostomy, and he will close the distal colon and leave it in the abdomen. So it is sort of an anterior dissection but without a anastomosis. And later on we can go in second time and we can reunite when the patient is stable enough. Nowadays, in case of obstruction, you see this X-ray, there is foreign body inside. This is actually a stent which has gone beyond the obstruction through the obstruction. So this is a temporary measure which can put up with the help of colonoscope into the bypassing the obstruction. So the obstruction is relieved. You do not have any surgery done. When the patient is prepared, properly investigate and stage, you can go in for a definite procedure. In stage 1, the primary option is in colonic tumors. You can see the primary option is always surgery, whatever the stage is. Stage 1, stage 2 and stage 3. The primary option is always surgery. But in stage 3, patient will have some adjuvant therapy. And in stage 2, high risk. What are the high risk? I told you stage 2, there are no lymph nodes involved. So if there are no lymph nodes involved, you do not need any chemotherapy or any adjuvant therapy. But if patient does not have lymph node involved and the biopsy tells you that the tumor is T4, it is involving, it has gone beyond the serosa, there was obstruction or there was tumor perforation or there was sort of vascular or peri-lymphatic involvement or the lymph nodes the surgeon has removed were not enough, then this patient will come up in a high risk group. So for that you need the adjuvant therapy. So presence of lymph nodes involvement is very important to decide whether the patient will need chemotherapy or not. Slight difference in rectal tumors. The primary tumor is surgical excision only in stage 1, not for other stages. This is the main difference of colorectal tumor. This surgical excision in stage 1, which means it has just involved the muscularis propria, it has not gone beyond it. This can be done as a segmental excision or can be in a proper laparoscopic approach. Rest of the stages, stage 2 and 3, there has to be some neoadjuvant therapy in different forms, either in chemotherapy only or chemoradiation or radiation only, and the surgery will be the second step, again followed by adjuvant chemotherapy. So you see, we are afraid of rectal tumors because rectal tumors are notorious to reoccur. So that is why when we have a slightest doubt that this rectal tumor is slightly invasive, we resort all of the methods and we put the surgery sandwich between the two methods. Chemotherapy before, chemotherapy after. And in stage 4 rectal tumors, the advanced, the metastatic, there is no benefit of surgery as such. You can reserve the surgery for certain lesions, obstructed lesions or some other lesions, but there will be no overall benefit of surgery in stage 4. You have to resort to the chemotherapy, chemoradiations, or you can, if patient is bleeding, he is not fit enough, you can transanally, you can go in and just fulgurate or cauterize or coagulate that tumor. And sometimes the tumor is so much advanced that we just have to divert. So chemotherapy, the commonest is the 5-fluorouracil. Capecitabine, this is usually given in oral form, and these are the regimes. Just try to remember few of them, the combination FOLFOX, Capox, these are the two commonest chemotherapeutic agents which are started as a neoadjuvant or in a as an adjuvant setting. So this is an interesting slide. If it is Dukes A, limited to bowel wall, 90% of the patients, more than 90% of the patients will have a disease-free survival more than 5 years. But if there are lymph node metastases, 30%. You see the drastic drop if the lymph nodes are involved. So after 5 years, only 30% will be living. And if there are metastatic disease anywhere, so after 5 years, there will be less than 10%. So earlier, the tumor is caught by either screening or by presentation, the prognosis is excellent, especially in the colonic tumor. So once you have done the surgery, how you are going to follow up the patients? You are going to follow up the patient by help of colonoscopy. If you have already done preoperatively, then it is not mandatory. But if you have not done preoperatively, then immediately after surgery, whenever it is possible, do the colonoscopy and then repeat it after once in every 3 years. CE level, it's prognostic. For the first 2 years, every 3 months, and for the next 3 years, every 6 months. And then for 5 years annually, you can repeat the CEA. CT abdomen, chest, pelvis. A staging CT scan every 6 to 12 months for 5 years. So this is how you follow up the patients.